Hello, viewers, and welcome back once again to the Necessary channel.
My name is Ifwa Dadzi. I'm a member of the team at Leicester Hospital. I'm very happy today to be talking to Dr. Christian Boamah Mensah, who is a senior specialist in obstetrics and gynecology and has agreed to talk to us and educate us on endometriosis. Now, I know endometriosis is a word that most people don't know about, but this is something that occurs in 1 in 10 women who are of reproductive age. 1 in 10. Now let that sink in. If you know 10 women, 1 of them might have endometriosis. You don't know the word, but I'm just going to mention a few things, and I know you can relate to that if you're a woman. Painful periods, severe pain during your periods, does that ring a bell? Pelvic cramps, does that ring a bell? Pain with intercourse, does that ring a bell? Excessive bleeding. These are some of the things that Dr. Boamah Mensah is going to throw light on for us today. So without much ado, I'm going to welcome him to Critical Conversations in Health. Welcome, Doc.
Thank you very much. Thank you for having me.
Thank you for agreeing to come. We are so happy that you agreed to give us this education. Now, I always start off with wanting to know more about what the topic is. So what is endometriosis? Can you shed more light on it? Yeah.
So endometriosis, like the name sounds, is a disorder in which there's abnormal growth of tissues which, when you look under the microscope, look very much like the endometrial lining or the lining in the uterine cavity. So these don't happen to be in the uterine cavity, but outside the uterine cavity. So that's in short what endometriosis is all about. Endometrial lining, which is supposed to be in the cavity of the uterus, being found outside its normal position.
Wow, so the lining of the womb is actually growing outside of the womb.
Yes.
Now, that doesn't sound normal. I think we can all relate to that. What causes it? I mean, what will cause the lining of the womb to grow outside of it or move outside of it?
Well, if we say we know why this happens, we lie. But we have several theories that try and explain when this. The first person to actually talk about it was von Rokitansky, and he in 1816 tried to describe what this is all about. So we have theories why these things happen. The first theory is what we call Okay, so the first theory is what we call the implantation theory.
Okay.
That is the lining that we are talking about is implanted somewhere else. And they assume or they think that it is because of what we call retrograde menstruation. Normally you have your menstruation, it passes through your cervix and comes to your vagina. But here it goes the other way. So it goes through your tubes and then have its this in the peritoneum. So it can lie anywhere around the ovary, can lie behind the uterus, can lie in the structures which hold the uterus together. Then they have another theory called the metaplasia. That is, meta means change and plasia means growth. So they realize that when a human being is like formed, we have about 3 main cells: the ecto, the endo, and then so these cell structures, something happens to them. So instead of they being where they're supposed to be, some happen to migrate and happen to grow at other places. Wow. So any place that you can think of, they can grow.
Even in the brain? Even
in the brain.
Wow.
Then we have the lymphatic tissue theory. Now, the lymphatics are like vessels that actually move infection or carry things away from the body. So they can use that route and then also get to where the lymphatics go. Then we have the vascular or the passing to the vessels. Now, if a lesion is close to a vessel or grows and then ruptures or gets into that vessel, then it passes or uses the blood stream, goes to wherever that the blood stream is going. So if it's going to the heart, it goes to the heart. If it's going to anywhere, it will take it there. And then we have the generic or the heredity, and that one we realize that, okay, if your mother or your sister has, that's what we call first line, you can also have. Then we have the immunology or immune theory. So they have several theories. It's actually something that we do not actually, every day it's like we're seeing new things, every day we're learning more. So it's something that we still have to learn more about.
Wow. So it's actually, when I sent the message around, I sent a text that said endometriosis is as old as humanity. And still today, scientists, doctors, medicine is still trying to find out more about it to get to the root cause. Doc, can you tell us some of the symptoms? I know I mentioned a few, but you've seen more patients and more women over the length of your career who have it. So can you let us know some of the symptoms you've seen?
So symptoms that we see, and because it's so vague, anything that happens around, you should have a high level of suspicion. What normally we see is pain. Now, it could be pain before menstruation, it could be pain at any time, even after menstruation. It could be back pain, it could be waist pain. I mean, anywhere that you can imagine this patch or endometrial patch lying, I mean, and causing havoc. So yes, you can have pain even in the anus. Menstruation or you're urinating, you have pain, some even urinate with blood. So there are several things that go on. But like you said, the main things are the ones you said, the painful sexual intercourse, the painful menstruation, the, what else did you say?
Pelvic pain.
Yeah, the pelvic pain, then the cramps that happen when you're having your menstruation. So yes, these are quite common features that we see when they present.
So Doc, if the endometriosis is growing in your brain, that's a problem, isn't it? I don't know much medicine, but
it can cause a problem.
Okay.
Yes, and it's been written. Yes, I think there's a research paper on that said, yes, there was one, and it was interesting, what they call catamenial seizures. Okay. And they realized that that lady used to have a seizures when she's having a menstruation, because what? The blood was discharging and causing havoc in the brain.
Wow.
So yes, it can cause.
Doc, I remember one of the doctors once telling me that if the endometrial tissue or endometriosis is growing outside of the womb, then it means that at that time of the month, as we call it, or when you are in your period, wherever the endometriosis is, it will also bleed. Yes. Right there.
Yes. Yes. So it functions. Wow. It functions just like the endometrium would function. So it's like you having a period, a part of it is laid off or shed off, same thing happens. And this shedding or this blood that irritates maybe the omentum, that's why you have pain or whatever it is. And at times here we have cases where we've gone in and realized that there's blood in there which can cause peritonitis and all sorts of things.
Doc, these big words that you are using, you have to help us.
Okay, so inflammation of the peritoneum. Now the peritoneum is the walls that cover the internal organs.
Okay.
Yes. So
all right. I don't want to lead you on another path. So at least you've shed some more light on it. That's good. Doc, how would you diagnose endometriosis? Okay. How would you diagnose?
So this diagnosis is difficult. Okay. In that, like you realize when we were trying to define or talk about it, we said it has to resemble. That's when you go under the microscope, it has to look like the endometrial tissue. So you'd have to, for us to be definitive of the diagnosis, we would have to see, we have to take that sample and look at it histologically and say, yes, this looks like an endometrial tissue, so it is what? Endometriosis. So you can imagine how difficult it is. First, now lay hold of it, and then get a choice. So you see that to define it, you need to actually have a surgical intervention, where either laparoscopically or you have an open surgery and take the sample or remove the whatever is causing it, take it to the laboratory, and they will tell us that yes, it does histology under the microscope look like an endometrial tissue. Then you can definitely say what you have is an endometrioma.
Okay.
Not talking, just about 3 weeks ago, yes, I had a case where we did. Now, interestingly enough, we opened up, and now on her side, it's so classical.
Yeah.
So she had a cyst, a big cyst, so we had to go open up, because if you don't, this cyst might twist and then it becomes an emergency. So we opened up and we were able to remove the cyst. Then we realized that down there we couldn't do anything, because it was what we call a frozen pelvis. You can't really move anything. Everything is matted or adhered together. Wow. And that's how the endometriosis behaves. When it shuts off, then it sticks, and then it holds on to. So we have a lot of adhesions, we call them. And that was what we saw. So we closed up and sent the sample, the cyst that we had taken, chocolate cyst that we taken to the laboratory, and it came out to tell us this was an endometrioma. So yes, that was a classical case. Wow. So yes, we see cases like that. Wow. And how vague it could be. Monday, that's 2 days ago, a patient comes to me during the lockdown. She accidentally fell on a knife, stabbing herself in the umbilicus. Wow. So she comes to me 3 months after and complaining that she has this, painful discharge coming around the umbilicus when she's having a menstruation. One look at it, I say, okay, this is an endometrioma. And we treated, and she's improved. So it's so vague, and it's so this thing, but yes. And I think for us, we have to have a high level of suspicion. But that doesn't mean that even if your nose is running, you say, oh, my nose is running during my menstruation, so it is endometrioma. No, that's not what I'm trying to say. But what I'm trying to say is that we should have a high level of suspicion. That is, we, those at the other end treating, check cases to also think about endometriosis.
Wow. Yes. I mean, I can't imagine bleeding on a monthly basis from your umbilicus. But I remember growing up, I heard stories. We all hear these funny stories about somebody who, during their menses, bleeds from their hand, their palm. I mean, I'm sure these are myths. But the umbilicus one, you have just confirmed that it can actually be. And you have to actually go in wherever it is and take the tissue, take to the lab before you can actually be certain that.
Yes, that is if you want to have a definitive diagnosis.
To have a definitive diagnosis.
So because of that, you realize that a lot pass, or I think we are even missing a lot, because not everyone that we can really take a biopsy and do these things. So I'm sure the numbers are more than what we think we're seeing. That is my belief.
I can imagine that the numbers will be more, because sometimes when you're going through this, people around you might think that it's normal. I mean, you're having a period, you have some pain. Come on, be a bit stronger, or or something. There's always something that is said. But if it's really bad, it means that you could investigate and see the possibility. So, Doc, how do you treat the endometriosis? Okay. I have it. I've come to you. Okay. We've diagnosed it. How do we treat it? Okay. So, the treatment regimes are several. Now, we have to consider the person's age. We have to consider the person's parity and how many children the person has. We have to consider where the endometriosis is. And we have to consider the severity of the disease. Okay. So with all these things in consideration, first, and here let me mention that some come asymptomatic, they don't have any symptoms, but it's happening in them. So that's why it can take a long time before maybe it comes out. And for that person whose sickness is not too severe, we'll do the conservative or expectant management. We'll wait and see what happens. We let the person come to us maybe 6 months or 3 months, depending on how urgent we think it is, to come for review, and then we look on and see what is happening. Then we can do painkillers, that's the analgesias, right? We can go as high as the morphines, just to make sure that she has pain. The pain can be that bad? That can be that bad. Wow. Then we have the hormonal treatments, which we use like combined oral contraceptives. So basically what we try and do in the system is there are 3 points that cause menstruation. Okay. Your head, on the chart. Okay. Your ovary,
the head up there in the hypothalamus, the ovary here, and then the lining of the womb.
Okay.
So these three factors, they all have to work in tandem, and you have your menstruation. Okay. So what we try and do is to break either from the top here or from down here, so that we don't have the menstruation.
Okay.
But of course, you cannot do that forever. So we do them in short periods, maybe for 6 months, for 3 months, and then see how you behave. But normally we want the shorter one, the 3 months, and then we give you, and then you don't have your period. So when that happens, then we see how it was. So we have the COCs, like I said, the combined oral contraceptive, the ones that we use, yes, when we don't want to protect, we want to protect ourselves. We have the progestogens, we have the androgens, and then we have the gonadotropin releasing hormone agonist. So all these things, like I said, we're trying to break off the connection. That's the triad. That's the head, the ovary, and then the womb. So we try and break it off at a point so that we abort this thing of menstruation. So basically, that's the strategy that we use
for the treatment.
Yes, and then we have the surgical treatment. So that will either we open up, that's laparotomy, or we use laparoscopic, that's this minimal invasive, this in tubes which is provided here to also check. So I believe that if we're doing more of those, even just anybody coming in with chronic pelvic pain and doing laparoscopy, we'll pick up a lot of cases, and then we know how to deal with them.
Wow, wow, wow. So there is non-surgical intervention, and there's also surgical intervention. And some of the time, you want to stop the person from having periods for some of the treatments.
That's
so that
the intention.
lining doesn't shed.
That's the intention.
I guess that makes sense. But what can happen if I do nothing?
Well, if nothing is done, then it will go on. Okay? So now, depending on where it starts, it's a major cause of infertility. Wow. Now, why would that happen? It's because these adhesions, if you remember, I said earlier on, for example, your tubes are held and are matted or stuck together to the wall of the womb. The egg is released. The tube is nowhere around even to pick the egg. Wow. Or there is the ovary, or maybe like, okay, the bleeding, the constant bleed, like I said, the retrograde theory, constant bleeding through your tubes could happen and close down your tubes. So you have a stricture. So you realize that now the sperm cannot even, or the zygote, which is, cannot pass through and come to this side because the places were closed. The other things that happen, and all these things are this, including even when luckily you've been pregnant, but then you can have early miscarriages, and including even when the tube has to go around and then pick the sperm, the zygote, yes. So when you have this problem and it's matted together, that cannot happen. So there are several theories that happen even in infertility management. Now, you could even have bowel and then GU symptoms, like I said. I mentioned somebody might bleed or have bleeding, or maybe missing some blood even in the toilet. And then these are all the effect of the endometriosis affecting the neighboring tissues, eating up into those tissues, and then causing havoc. Now, you could have vaginal wall involvement, then you could have malignant changes. Now, if you see anything what is cancer? Cancer is chaotic growth of any group of cells. Do you understand? They are not regulated. They just happen to just go out of proportion or anyhow. And metaplasia or uncontrolled. And metaplasia is, endometriosis is something like that, because this is growth of cells somewhere else. And if you leave them, they can continue to go and cause malignant things, especially of the ovaries and other structures.
Wow, Doc, this is loaded. because you've just answered two of my questions. I wanted to know whether it affected infertility or the causes infertility, and you have said there is a linkage between having endometriosis and infertility, right? And you've also said that there is a possibility that if you have endometriosis, you could have cancer at some stage of it.
Yes.
But not all endometriosis will lead to cancer, of course.
Good.
Right.
So
not to scare anyone.
Yes.
Yes, not to scare anyone. Wow. Do you think there are any lifestyle changes that somebody who is listening can have that can maybe help, if you have endometriosis? Any changes that could help to live with it?
I believe, one, you have to know, the fear of the unknown, I think, is what hurts a lot of people. Once you know what is happening to you, I think you can sort of mentally prepare and manage. So coming early for diagnosis, or let us help you solve the problem, I think is so important. Now, the usual dieting, you have to eat well, sleep well, and exercise. And we recommend that you do more than a 4-hour-a-week exercise. So once these things are done, your body tends to now try and function properly. You get me? And then this chaotic or abnormal growth you'll be able to avert it somehow. So I believe that, yes, these are little things we can do by ourselves to help us.
Okay. Wow. Look, is there any final advice that you can give to somebody who is suffering, who's looking, who's gone through this problem for so long, and they finally chanced on this video of you talking about it? Can you just look out there and tell them something? Give them a message for me.
Okay. So, we know the causes, or we try and at least try and know what happens or what causes these things. So you have your period early, very early o'clock. That's early menarche. So that means the time that you be having your period is a long thing. So those who have their periods early and those who end their periods late, you're candidates. Or if you tend to bleed too much, because yes, we talked about the retrograde, the stick. So if you bleed too much, that too can happen. Or if you bleed often, that means you have short intervals between your periods. So you realize that there are several factors that can harm you. My advice to you is that seek medical attention early. There are things we can do. And every day, medicine is evolving, medicine is developing. I'm sure it will reach a place where we'll have robotics that can determine where the lesion is and go in and minimally, invasively remove it. So don't give up. Come early. Let us help you. And we'll go through this. This too shall pass.
Well, this too shall pass. I think you've given us a message of hope and not to let anybody despair. Here at Leicester, we are going through these critical conversations in health because we know there are a lot of things that are happening to people that you probably don't even know that you can get help for it. So that's how come we keep bugging our consultants to help us, to give you more information so that you know what to do. It might not be Leicester you come to, but somebody out there, a very good doctor, a very good hospital you go to, should be able to help you. So now you know what endometriosis is. So don't despair. There is help. If you're going through this and you thought that it was normal, nobody seemed to understand you, you've been to several doctors, nothing is being done to help, you're not sure what's going on, we'll be happy to be of help to you. Thank you so much for being with us. Thank you for your time and many blessings to you. Bye for now.